So I'm going to focus most of this talk on the consolidative setting, meaning after patients have received some systemic therapy, but before they have progressed. And the reason that I do so is the fact that we, as a non-small cell lung cancer field or as a tumor field, we have done an incredible amount of work early on with early phase clinical trials to establish that that patients that do receive local therapy and consolidation for oligometastatic non-small cell lung cancer actually do very well. So these are early phase trials with early signals that suggested to us as a group that giving radiation or doing surgery to oligometastatic disease not only improved progression-free survival, and I have 3 arrows that point to the randomized studies that showed a progression-free survival benefit for this patient population when given local therapy, but there was also an improvement in overall survival as identified by 2 of these studies that had large enough patient populations. So really, we were starting to understand over time that the use of local therapies may actually be very beneficial. And then the issue with those studies, of course, was that they were all done in the era of chemotherapy alone. And so none of those patients received immunotherapy. And so when we started to have studies, some that were done, for instance, by Baumel et al. At Penn, single arm study, and then another study by the Netherlands, when we started looking at how immunotherapy and radiation may synergize to improve outcomes, what we found was that there was a signal that was probably better than our historical outcomes with systemic therapy alone. However, that signal got muddied by a few other studies, such as this one that was done at the National Cancer Institute, that suggested that combining immunotherapy and local therapy did not help metastatic non-small cell lung cancer patients. And the real question is, why did we not see a benefit? And the real point of the matter, which I think we're going to have to harp on over and over and over again, is that it wasn't just enough for us to decide whether a study works or not in terms of the primary endpoints. It's also for us to understand biologically why something did or did not work. So, that brings me to the point, and I'm going to pontificate a little bit in this presentation to really try to drive us to move in the directions that I think will be necessary to really optimize what we can do for the oligometastatic patient population. But, at the end of the day, none of these studies have accomplished enough to date. And the question is why? And really, it's why, because we still have a poor handle on how we should define a patient to have oligometastatic disease who would benefit from local therapy. We've used a number, a numerical value. Some of studies have used 3 METs, some have used 5 METs. I don't even know if the number of METs is relevant as much as our understanding of how patients will fail or not fail longitudinally over time. We don't have a firm handle on whether the location of METs matters. Some studies suggest that having liver mets is more detrimental, but other studies have not demonstrated that. Does the volume or size of the metastases, if done in a limited meaning limited number matter? And then really the question of nodal disease as part of the primary process. Is it imperative to treat the primary disease and the lymph nodes involved? Again, we're still uncertain as to sequencing. When is it the right time to give this radiation? Is it upfront at the time of diagnosis? And so that would limit the patient population of patients who had oligometastatic disease when they were diagnosed. Is it at consolidation? Would we then be able to include patients who may have had 10 or 12 METs at diagnosis, but then after their systemic therapy started, what was residual and left after 4 courses or so were 3 or 4. So, would it be only at oligoprogression when we know that the patients have done well in a majority of sites, but then at some point down the line, they fail in 1 or 2, and the local therapy may help the systemic therapy continue to keep things under control? And so really, we don't know enough about sequencing. The early studies that I demonstrated, that I presented, demonstrated that consolidation may be a very reasonable time to offer radiation. at the end of the day, we don't know what the right metric is. And I've learned a lot by running a consensus guidelines with the astro and estro and oligometastatic disease from our patient advocates, because I think, we certainly appreciate the importance of overall survival, progression-free survival, a time from metastatic disease-free survival. But what also is critically important is quality of life. What also is critically important is not just saying that a generalizable quality of life, but a quality of life is different for each independent patient. Some have different thresholds for what they view as a good or bad quality of life. And so we need to take all of that into account to determine whether local therapy benefits are actually meaningful. And ultimately, we have moved towards larger phase clinical trials, but these need to be finished. But we have to finish these with a sense of urgency. We have to understand that they have taken some time, and we need to continue to optimize getting these done.